Welcome to Mender Horse, Chapter 94, the monthly support group meeting. Today we have a special speaker, Dr. Underwood. I'm requesting my chapter secretary, Mr. Linsky, to introduce Dr. Underwood. Sir, the floor is all yours.
On behalf of Mended Hearts Chapter 94, President Ash Ramamurthy and our team, it is my very special honor to introduce today's guest speaker, Dr. Paul Underwood. Dr. Underwood is one of the nation's leading cardiologists, and today he is wearing not one, not two, but three very important hats. Hat number one, Dr. Underwood was in private practice for 25 years as an interventional cardiologist and an office-based clinical cardiologist. He performed many thousands of catheter-based interventional procedures, saving countless lives of heart patients along the way. Hat number two, for the last decade, Dr. Underwood has worked at Boston Scientific Corporation as medical director for interventional cardiology and structural heart research and development. At Boston Scientific, he oversees hundreds of clinical trials across the globe, leading the way for even more exciting advances that will benefit millions of heart patients. And then hat number three, Dr. Underwood has been a volunteer leader in many professional societies. Notably, he co-chairs the Association of Black Cardiologists, known as ABC, Community Programs Committee. His role, and in fact his passion, is best expressed through his own words in a recent interview. Quote, "I support educational, county, research, and advocacy efforts aimed at creating health equity, particularly for traditionally underserved populations," end quote. Thank you, Dr. Underwood, and a special thanks to ABC Executive Director Cassandra McCullough for partnering with us on today's session. Dr. Underwood will begin his talk by giving us a little history, then describing the Association of Black Cardiologists programs and how we can all work together to serve the heart community. After his brief remarks, he will be delighted to answer your questions of interest to us all. Again, a friendly reminder, as we always do, always ask your doctor about your own situation. Mended Hearts cannot and does not give medical advice. Dr. Underwood, the floor is yours, sir.
With the Black History Month and certainly the Heart Health Month coming together, I just wanted to go over some quick trivia, I suppose, on Black history and heart disease. So the first person to perform open heart surgery successfully was an African-American, Daniel Hale Williams, who did this sometime in the early 1900s. It was not a coronary bypass, it was actually a trauma, stab wound, and he was able to successfully oversew the heart, which was the first time that had been done. It used to be taboo to actually violate the heart, and people would think that one would have died by just cutting into the heart. So he was the first there, and he went on to be a professor. It looks like he was quite a scientist and a professor in schools, and started several schools for nursing as well as medical education. Next, for a lot of people here with mended hearts, certainly coronary artery bypass is important, and the blood transfusions that go along with it are important as well. So certainly I think most people have been aware of Charles Drew, who was the founder, kind of the father of blood banking. And so certainly the opportunity to do open heart surgery depends a lot on having blood. And then lastly, there's Vivian Thomas, who wasn't a physician. He was a surgical tech, so a lab assistant who created the experiments in dogs for blue babies. So a lot of people have congenital heart disease and have to have that repaired. He was the one that worked with surgeons Blaylock and many others, but certainly Blaylock to develop the operations like the Blaylock Tau-6 shunt to correct blue baby syndromes, when the babies come out, to do those operations to actually restore fairly normal flow so they would be able to survive. And so he trained Denton Cooley, who's one of our most renowned cardiac surgeons, and many other surgeons along the way. He actually has two documentaries, a PBS documentary, Partners of the Heart, and an HBO movie, Something the Lord Made, which are very interesting to look at as well, because it goes through some of the history of cardiac surgery and how, particularly at those times, segregation and racial beliefs played into the role of medicine. So just to get back to ABC, just a quick overview. ABC was formed in 1974. So over the past 46 years, we've been on a mission to promote prevention and prevention of cardiovascular disease, including strokes in Blacks and other minorities, to achieve health equity through the elimination of disparities. And these are just a few of the community programs that ABC has been engaged with over the years. And the reason I'm bringing this out to you now is so that you'll see from kind of what we've been doing, what our capabilities are, and then hopefully when we have the time for discussion, you'll be able to give me insights on how we might be able to better partner with groups, say, there in the Metro DC area, to be able to reach community members even better. So around 1978, we had a grant from the National Heart, Lung, and Blood Institute to do community wellness centers, so using churches and barbershops to teach hypertension screening. So from there, we've kind of developed that technique more and more. So on the far left, you'll see Heart Health Regenerations, which is a church program. Typically would be a Sunday in a church that's dedicated to heart disease, where we would give lectures and then do screenings on people there to help them understand about the heart. We've also had our campaign, Why Children Should Know Their Grandparents and Become Great Grandparents Themselves, which was kind of our mantra for a couple of decades, actually, to let people know the importance of controlling cardiovascular disease, particularly in the Black community, where it wasn't as well recognized that heart disease is the #1 killer. Next, we had Choices, which again is a church program, which had a Bible study component to it. It lasted about 3 years, and we engaged 3 churches in 5 states and had frequent meetings, frequent screenings, and then the cardiovascular education. And it was actually, some of it was incorporated into a Bible study, which is a separate study that we can understand how people can incorporate health messages into, say, a church curricula to actually improve cardiovascular health of communities. And there on the bottom is our current flagship, the Spirit of the Heart programs, which is a 3-day program, which we do from cities across the country. Our last one was in Orange County. And we do community leaders forum, where we'll get business leaders, public health leaders, as well as clergy leaders into a room to have a community leaders forum to understand heart disease in that particular locale and kind of the actions that are being taken to eradicate heart disease. On the next day, typically a Saturday, we'll have a health fair, which is cardiovascular screening, blood pressures, BMIs, and then many demonstrations such as healthy cooking or exercise demonstrations, and many booths that are set up to just go over cardiovascular health or health in general for that community. And then on the third day, we'd have a spiritual message. So we typically would choose around 3 churches and have a scripted message delivered from the pulpit to the congregation that reinforces the 7 steps for a healthy heart, which is what ABC's cardiovascular prevention program is based on. So this just shows our method of operation. So on the left, you'll see these different groups like the National Black Nurses Association, the auxiliary to the National Medical Association, blackdoctors.org, and the National Baptist Convention. So these are just large groups that we work with to disseminate our information. So within the communities, we can typically find local chapters of these and other groups to get them together to rally around what's happening in that particular environment. And then the table here shows some of the initiatives that we've carried out over the past, looks like, couple decades, working with either sponsors, industry sponsors, pharmaceutical industry sponsors, or with government sponsors like DeKalb County or the National Heart, Lung, and Blood Institute, to institute these programs and deliver it to areas of the communities where oftentimes some of these messages haven't quite hit home. And so to be able to deliver it from a trusted messenger and to give valid information with what the emphasis should be. And so for a lot of African Americans, that really does center on hypertension and blood pressure control. And then the follow-up to know what to do about it, how to measure your own blood pressure, how to access the healthcare system to make sure that you're able to get the medicines and follow-up that you needed. Those are all components of the education that we'll put forth in these different types of programs. And then on the bottom here are just logos from some of the different campaigns that you see up above. So currently, we've launched our Community Health Advocates Training Program. So we just piloted this in Jackson, Mississippi, and New Orleans, Louisiana. And what this is composed of is 12 module sessions. So now with the coronavirus pandemic, these are virtual modules. In the past, they have been live meetings, as you can see here, where we train people using the National Heart, Lung, and Blood Institute with Every Heartbeat is Life curriculum. And so we'll go through this month by month by month to educate people on how they can then go back to their communities. So having their own churches, their own barbershops and beauty salons, or their own community groups have the education after we have trained our community health advocates. And in addition to this, the education, we also incentivize them to perform community activities, whether it would be a screening, community leaders forum. Now with the pandemic, we have had them do immunization drives, so influenza immunization drives. Now that we have the vaccine, we've kind of refocused to look at the coronavirus vaccine and then working very hard about the vaccine hesitancy that affects the Black communities more. And so from this, you can see we want to build capacity, mobilize the communities, engage the communities, and have a systems approach so that we can train people across the country on how they can go back to their communities and combat cardiovascular disease. And this, again, is just one of our sessions. And so it looks like very similar to the session that we have here because they're all virtual. And what you'll see on the larger pictures are ABC members who are involved in the educating the chat members, the trainees. And in this particular case, it's on heart failure. And then Rimsky is talking about, and the far right is talking about cardiovascular interventions like percutaneous coronary intervention and transcatheter aortic valve replacement. And so certainly the association is enriched by participation. And so for those people who do enter our community health advocate training program, they get a complimentary membership, just something for you to keep in mind. And then lastly, with your continued support, ABC is well positioned to broaden its mission to achieve health equity for all through the elimination of cardiovascular disparities. And so the association welcomes everyone and everyone's participation, whether you are Black or not, and whether you are a physician, a cardiologist or not. And the idea is that if people have interest or concern with the cardiovascular health of particularly communities that have traditionally had difficulties or face barriers to accessing, good optimal healthcare, this is a very good group to advocate on that regard. And in addition to our community programs, we'll have professional education. We also have advocacy. We try to do things to encourage minorities to go into medical school and become cardiologists themselves. And we also are looking into women and maternal health as a major focus as well. So that pretty much ends the bit on ABC. And I know that Norm has said, I think he may have introduced me as being an interventional cardiologist, hopefully. And I practiced for about 20 years in the Phoenix, Arizona area. I also did quite a bit of cardiovascular research. And now I've joined Boston Scientific, so industry, to better understand how we can make devices that actually improve the health of people with heart disease. And so that could be the part on the leading edge technologies that you may wish to know about.
We've asked the members to submit questions to the host or to me directly, or tell me that they'd like to ask them. We don't care either way. Let me see the topic on the PowerPoint presentation, which was emerging therapies for heart disease. Can you comment on some of those? I believe that was the topic.
Okay, well, certainly. From my standpoint, I think that most people will understand that the heart does essentially three things. It pumps, so, and there's a plumbing system. So coronaries are a plumbing system. The heart muscle itself is a pump, and then you have the electrical system. So just starting for, say, emerging therapies for the electrical system, I believe we're all aware of defibrillators and pacemakers. The emerging trends that we see in most of the medical devices is miniaturization. So now we have leadless pacemakers, right, that don't have the leads. They fit really right into the heart. They're almost injected like a pill that goes inside the heart, and it can do its pacing function from there, which a lot of people find very convenient, particularly if they may have issues with skin healing. The other thing that we have now are defibrillators that don't require leads either. So we have a subcutaneous defibrillator that can be placed from the outside. One of the most common irregular heartbeats or arrhythmias that people face is atrial fibrillation. And there certainly has been a lot of interest in controlling atrial fibrillation, both by eliminating it using catheter ablation or by reducing the risk of stroke that comes along with atrial fibrillation, which is what most people are concerned with. So now, for those people who can't take blood thinners to reduce their stroke risk, there's left atrial appendage occlusion, where we can put a small device in the area of the heart that harbors the blood clots to close that off so the blood clots can't form. And that's called a Watchman device. And it's implanted by cardiologists using the same like outpatient type procedure to put this device in. And it eliminates, once it heals in place, it will eliminate the need to take blood thinners for atrial fibrillation. For coronary disease, the stents are still most popular, and I'm sure that many of you are aware of what the cardiac stents are, the coronary stents, and how they can sometimes be alternatives to cardiac surgery or stave off the need for coronary bypass grafting. We're now able to perform these procedures in people who have weak heart muscles, who are at higher risk, using pumps, circulatory pumps, to temporarily assist the heart as we do these interventions. So we've been able to approach more interventions, and we have more equipment that's designed to cross blockages that previously could not be crossed, and to treat them effectively as well. So that's on the coronary side. And then looking at the heart muscle function itself, we have advances in the timing that we've used for our 3-chamber, our biventricular pacemakers. We have more monitoring devices that are available to give us early warning when a person may be developing heart failure symptoms. And so with this, we can adjust the medications or adjust the devices in some cases to make sure that these people don't have fluid retention and the hospitalizations that they may not have known about where they're coming down the line.
This question was submitted by Daniel Dollarhide, who was a past president of our chapter. He has 2 questions. He says, is there a contact for the ACB in the Tidewater area of Virginia, Williamsburg, Newport News, Norfolk, etc.?
So for ABC, Association of Black Cardiologists?
Yes.
Okay.
I believe so.
All right. So yes. So what we would do is we would take your name like nationally, and then we would connect you with someone that would be more local. I know, just off the top of my head, I don't have the membership roster here, but there are close members that I work with in Richmond. We've actually had, I think, 4 or 5 Spirit of the Heart events in Richmond. So certainly Virginia is there, and there likely would be a member that's somewhere that's even closer, perhaps in the Tidewater area. So that just if you email me, and I think that's certainly Norm, I know that you have my email address, then we can connect you with someone that's local there.
Okay. He also says, Dr. Underwood, how can we partner with ABC to serve medically underserved communities in the Tidewater area of Virginia?
So that would be typically what I can imagine would be working with something like Spirit of the Heart, as I said, that we've had before. And we're also looking at CHAT, the Community Health Advocate Training, to have one of those in the Richmond area. So what we would anticipate doing is finding groups, say churches, that are, or community organizations that cater to underserved people, and then training the individuals that work in those groups. And so identifying them, putting them again in touch with us, so that when we start the CHAT training modules, that they can be included in that would be one very good way to start now. when we have, say, when we get back to the live events, there'll be opportunities for, or even some of our virtual events, we have opportunities to have booths available. Mended Hearts would be very good to be there to help people know that there are resources there for people who have had heart issues and are cognizant. I mean, one thing is prevention for people to have not had heart problems, and another thing is for people who have had heart problems. And certainly, me as a cardiologist, interventional cardiologist, I kind of focus on people who have already had problems. And so it's good to know that there's a resource that's local, that's available for those people. And so I think that would be another very good way to partner.
Thank you, Dr. Underwood.
Okay, we have Norm wants to know if wearing your industry hat has COVID complicated clinical trials recruitment for heart technologies, especially regarding patient recruitment.
Absolutely. So when COVID hit, then a lot of the hospitals were closed, and so those research departments were closed also, which means that there was no recruitment at that moment. Likewise, it made it difficult to follow patients who had already been enrolled because the research offices were closed, and the research, say the coordinators and the assistants, managers or whatnot, were refocused to home or redeployed in other parts of the hospital. So that occurred certainly for us with stents. So my division is mostly stents and cath lab activities. A lot of cath labs shut down completely during the onset of the coronavirus pandemic. And so, certainly there was no recruitment at that time at all. Fortunately, many of the hospitals are back up and running. The cath labs are back operating, trying to take care of people. There's a small backlog. And so we've been able to begin enrollment in our trials again. But certainly there was an impact.
Right. Now, wearing your clinician hat, we as heart patients are at greater risk if we get COVID. What is the very research telling you about that now? And what can we as patients do about it?
Okay, so definitely cardiovascular disease is a major risk factor for severe and fatal coronavirus infections. And what can be done is definitely to protect yourself. Now that we have the vaccine available, is to get vaccinated as quickly as you possibly can. So that's one thing. The other thing is to get under control. So particularly if your diabetes is out of control, then you can get your diabetes back into control. If your blood pressure is out of control, then do what you can, certainly at home, to get your blood pressure back in control, and to monitor your symptoms very, very closely to make sure that they don't exacerbate to the point that's going to make you vulnerable if you are attacked. And I think that you need to be extremely careful to make sure that you are not exposed to individuals who may pass this on to you. Which is the basic recommendation for everyone. But if you have cardiovascular disease, I think you need to be even more sure and more diligent about the protective mechanisms for people, because once you have the illness, it's been very difficult for some people to overcome this. I'm sure that you're aware of this. I think almost everyone in the country now has had experiences or personal experiences with coronavirus, hopefully not themselves, but certainly within their families and within their social networks, where the virus is devastated people and families.
Right. Now, wearing your ABC hat now, access to vaccines is especially difficult, and even more so amongst medically underserved populations. How can patient groups like Mended Hearts work together with physician groups like ABC to do something about this?
So what we've done is look at advocacy to try to make sure that the vaccine distribution is equitable. So there are many eyes on this at this moment. And so advocacy to make sure that the public health agencies, the ones who set up for the county here in Maricopa County, where they set up the vaccine distribution stations, to make sure that they are in locations where underserved people can be. In across the country, there has been interest in putting them in community centers or in large churches where there are large numbers of underserved people around, just and to make sure. So, I mean, certainly requires organization. It's not really like a free for all, but it is definitely possible to locate those strategically in certain areas where underserved people are. The other aspect is to gain trust of communities to actually use them, to go get vaccinated when it becomes available. And so there's been hesitancy there as well. The Latino population has been especially hard hit, and there's certainly a concern about Latinos and maybe not even personal, but for documentation or others, that there's a reticence to go to agencies where you may have to register yourself for fear of reprisal. So to overcome those fears and let people know that the vaccine is free, basically. Our desire is that for everyone to be vaccinated, and that's as far as it goes, is an important message to get out as well. And so we've been, getting people who have had the vaccine already to let others know that they've been vaccinated, and to encourage ways to overcome vaccine hesitancy. And that's something that I think Mended Heart members could do as well. As a person who has been personally affected by heart disease, them taking the vaccine, letting others know why they're doing this to protect themselves and protect others around them, I think is an important message that can be reached by all of us.
Right. Amy Dukovic, our vice president, wants to know, with the increase in minimally invasive procedures, what is the future for cardiac surgery?
So cardiac surgeons, I think, have continued to make advances as well, and to make the heart operations safer. Certainly, there has been a reduction in the amount of surgery that's available, but the surgeons have worked hand in hand with these valves and minimally invasive components of these. And so there are many surgeons who are now adopting some of the minimally invasive techniques themselves that they're using also, as these techniques are being developed, as the equipment is being developed, surgeons are often using them as well. But I mean, just looking at the numbers, I'm sure that you're very well aware that the number of open heart operations has dropped over the years, because of the minimally invasive technologies that are now available.
Mark G., one of our members, wants to know, what does high triglycerides readings indicate, and how do you best reduce it?
So the triglycerides are a component of the blood fat, that the blood fats, and so it's those blood fats that build up on the coronary wall to cause the blockages. So it's not cholesterol, but it's very similar cholesterol, and oftentimes they travel hand in hand. So the high triglycerides, they are a marker for people building up atherosclerosis or like cholesterol plaque in the blood vessels. Reducing them depends on basically the person's metabolism. So there are certain medications that can be used to reduce them. I mean, there are other techniques to reduce them as well that if they're extremely very high, that those can be used too. But typically it's through diet and medication in terms of what it takes to reduce them. I will say from the pharmaceutical aspect, and that's something again with the emerging therapies, that there are newer medicines that can be used to treat cholesterol. So if the current ones that we want, like the statins, that we know and love so much, if they're not effective, or maybe not strong enough, or people can't tolerate them, there are other tiers of medications that can be used or could be tried to reduce some of these abnormalities. And so there have been a couple of, I think, newer medications that are now indicated for reducing triglycerides as well.
Okay, Dr. Underwood, I talked to Cassandra about the ABC down. I live in Fayetteville, North Carolina, and would like to get my chapter involved in the hospital involved also, and trying to contact more. I don't know at this time if we have any members except for Dr. EJ, but I will further look up and ask around to see if we have any more Dr. Daka cleared my RCA last month, 80% blocked again for the third time. And I think my drugs on the stents have worn themselves out now.
Right. So so to get involved with ABC and making the contact with Cassandra is very good, and that's definitely a first place to start. And again, typically, what we do from our standpoint, from the community programs group, is to then find local members that are close there, and then to understand from them what type of interactions we can have. And it would be very similar to just what I said, that we would look for groups that they're often like groups of church ministries, or it could be like the Black Nurses Association. There are different groups, and to get them together, to train them to go through the chat training, so then they can deliver this message out further into the Fayetteville community. And that's how we're operating now with our chat program. The other one being a Spirit of the Heart. So getting the doctors there to consider, which it's more involved to do that, and it's more involved from the doctor's standpoint, to gather around for that 3-day type of event to form something like that. That would be, geared toward Fayetteville. So it's, using largely local people, particularly the community leaders, but also the practitioners as well, and health agencies that get together, and the churches. So, in the Fayetteville area, so we can construct a program similar to that in Fayetteville as well. So that's something to speak of too. So those.
All right, thank you.
All right, and then for the what you said about the drugs on the stents have worn out. Certainly, having the reblockage after having a stent put in is a problem, definitely. There are techniques that are now available, say in Europe, and we are looking at bringing those techniques to the United States through Norm's point, through clinical trials, called drug-coated balloons, which may offer another therapeutic option for people who have blockages in stents.
Yeah, I've got 5 in a row in the RCA, and that's causing a problem.
It is, and certainly the issue with having to put more metal in a place that already has metal brings people angst, but that's for now. That's for the percutaneous and minimally invasive type treatments. That's what we have available. So hopefully in the future, there will be other options that we can use for this problem, because it is a major problem. Just to let you know that there are many people who are working on solving that problem at this moment.
All right, thank you.
I have a question here from Sam Day. Sam says, Doc, please inform us about the latest and greatest therapeutics available to cardiologists today to treat CVD. Also, please comment on the least invasive devices and treatments for monitoring, et cetera, today.
Okay, so the devices for monitoring, so you could be speaking of invasive type devices that are implanted typically in conjunction with defibrillators and pacemakers. So they have better monitoring and reporting characteristics than before. So particularly with the coronavirus pandemic, the opportunity to do remote monitoring with your device has become very important, because it allows patients to have a connection, a digital connection with their healthcare providers. That's not necessarily dependent on the internet or telemedicine per se. So that's good. The other monitoring devices, there are newer ones that are implantable devices that certainly collect information and are able to report that information back to your physician to try to help with diagnosis. Key ones, particularly ones for, again, defibrillators and some of the pacemakers, are understanding better when problems are going to come. So to be able to predict a heart failure episode is how the algorithms are being developed now. So those are undergoing testing, and they're put into the devices. Sometimes they can, the software programming can actually be put into the device kind of retrospectively, because it's a program. And so depending on the type of device that you may have. So the emerging therapies that we have available for us, again, depend on the field. So the pharmaceutical fields, I'm sure that you've seen the medicines on television. So like the sacubitril and Entresto. So that's a new class of agent that's available. There are now medicines, there's certain types of cardiomyopathies or weaknesses of the heart muscle that have a genetic basis. And so now we have medicines that approach that gene product. It's the first time to try to treat people who have these types of genetic cardiomyopathies. So that's something on the horizon as well. We have these group of medicines I alluded to before, the PCSK9 inhibitors. So it's a group of like very strong cholesterol reducers for those people who can't get their cholesterol down using normal methods. So those are available as well. And then I also want you to just consider many of the medicines for diabetes that we see on television now that are there solely for cardiovascular risk reduction. So these are medicines that you take if you have diabetes. You would take these only to prevent yourself from having heart problems in the future, which is not, they're not really related to blood sugar control or anything like that. It's only to protect your heart. So those are some of the realms of the pharmaceutical treatments that we're moving toward. And I had mentioned earlier in terms of the transcatheter, like the aortic valve, so that we have available now, TAVR. We're working on mitral valves. I think there's some teams that are working on tricuspid valves the same way for that aspect for structural heart. The left atrial appendage occlusion devices like Watchman or Lariat, Amplatzer, those are devices that are helped to prevent stroke for people who have atrial fibrillation. And then understanding better the mapping systems for the ablations that people could have, like an atrial fibrillation ablation or ventricular tachycardia ablation. The mapping systems are better now, so that the electrophysiologists, the heart doctors, can better find the pathway, the abnormal pathway, and basically cauterize it to make it so that you don't have those problems anymore. So that's what we see in those fields. I just mentioned the drug-coated balloons, which will be coming for coronary stents and those factors. So those are kind of like an overview of some of the emerging technologies that that cardiologists are starting to use now that have been developed. And so hopefully they'll become more widespread as time goes on.
Ashram Murthy our president has a question for you. He's going to ask it himself.
Hey, doctor, I have a simple question. I visit patients in the hospital. Do you have any brochures that we can give the patients about African Americans having heart problems? We encounter many patients in the hospitals coming from your organization.
Yes, so I should have mentioned this before. So if you go to our website, the Association of Black Cardiologists, abcardio.org,
Okay.
right? And then you'll look on patients and then education.
Mm-hmm.
And then so you'll see a list of different types of publications for patients who have heart disease. So in particular states for hospitalized patients, I would recommend 7 Steps for a Healthy Heart, which is basically our doctrine there, and it's in English and Spanish. There's also transitions, and so that's for people who are leaving the hospital, being discharged and going home. And then you'll see there are also some there on clinical trials. There's one on acute coronary syndrome. There are, I think, a couple on deep venous thrombosis, DVT prevention in those sense. We have women. There's a women and heart disease one that's there. That's very nice. And then you'll also see I should put this first, our cookbook. It's a vegan cookbook. So for that's a very popular document as well. Okay. So those it's variable whether they're available. Like some of them you can order the print version and get them, and then some of them are available online. They're all available, I think, online. But some of them there's a print version also.
But the reason I asked that question was when we visit patients, often when we see a patient of color, including me, and they look at a brochure with a white person or non-color, they're reluctant to take it. But if you give us, hey, look here, we have a patient coming from this organization, they're more likely to accept it and go to that.
I agree. That's why we try to make these available. I mean, try to make them as available as possible. You'll see one also there on immunizations that we're working on now to try to have that revamped to include certainly coronavirus and the coronavirus vaccine, just to add a trusted voice so that people will be more accepting of the therapies. And that's the reason. The information is basically the same all the way around. There may be minor variances, but it's basically the same. But it's to be able to present it in a way that's going to be palatable for people, that they can use that in conjunction with the prescription that they get in their hand to take those medicines and to follow up with their doctor.
Thank you. You said the key word, trusted voice. When they say the trusted voice, they listen to us more.
Right, absolutely. And that's the idea of the association, to get in those communities that have had historical mistrust and to try to overcome those barriers.
Thank you, doctor.
Thank you.
Brian asked, are CBD oils safe or harmful for those with heart issues? And maybe you could extend that further, but I don't.
Right. So there's not really, as far as I know, a lot of information on CBD oils as it faces the heart. There had been research using some of the substances that are in the cannabis before, mostly on like obesity control. Most of the CBD that, at least that I have been made aware of, is more topical. So I haven't actually seen that it hits the heart. I just saw one report that said that people who were taking medical marijuana may have some reduction in blood pressure. That's about it for CBD. It doesn't, from a cardiologist standpoint, it really doesn't. It doesn't present itself that frequently. I mean, there's no recommendation because there's no data to support any statement in that aspect. I will say that I don't think that we would say that it's dangerous. Probably if you wanted to put nicotine oil on, we would advise you against that. The CBD oil, I think that most cardiologists would just, it's like almost like vitamin supplements, where there's nothing that seems like it's overtly harmful at this point, but there's nothing that's going to say that it's going to help. And then we don't know if there are any harmful effects that we're not aware of yet either.
Okay, Norm brings up the fact that you mentioned the important role of Dr. Charles Drew. And some of us on this call are privileged to know one of his daughters, Dr. Charlene Drew Jarvis, herself a distinguished scientist. And all of us are keen to know more about the history of your amazing profession. Can you tell us a little more about the vital role of Dr. Drew played in impacting millions of heart patients and others?
So, I mean, the reason I brought that in is basically that heart patients who undergo open heart surgery often have blood transfusions involved. And so the ability to transfuse blood is a key component of going on the heart-lung machine, the pump. And Charles Drew was one who developed blood typing. So the ABO typing that we do now, like, you know what your blood type is. And so categorizing it in that way. And developing blood banks. So the ability to bank blood, to have it available when you needed it. And like if you're type A and you had a car accident, you needed type A blood to come from the blood bank. There's a bank of A blood. And so that mechanism is one that he set up. I mean, it was like after discovering the ABO typing, what can you do with it? So he's the one that did that. And as you can imagine, in a time of war like World War II, it was extremely important to use that. Now, we use the technology for trauma, for surgery a lot, for almost anyone who needs a transfusion. Another thing that Dr. Drew did is that the American Red Cross segregated blood, so they didn't mix black and white blood at all. And Dr. Drew was against that. He actually resigned from the American Red Cross because of that. And that policy with American Red Cross persisted until 1950. So now, like if you get blood, it's not going to say it's blood from a black person, blood from a white person, anything like that, because there was no scientific basis for that. It's just based on ABO. So that's something else that Dr. Drew did. And I will say that most of the doctors that I mentioned before, those three individuals, they a lot of their work was scientific, definitely, but a lot of it was against racism, because there was, and at that time there was a lot of racism, and so they had to fight against racism as well as promote medicine. So, you know, in addition to developing heart surgeries to treat blue babies, you had to combat racism as well. So, you know, with Dr. Drew, in addition to doing the ABO typing, there was this racism aspect that he had to fight with as well. And to that point, with Dr. Daniel Hale Williams, you know, the hospitals were segregated. What he did was he formed the first Black hospital that was more modern, so that it would have like surgical suites and things of that nature in the Chicago area. So that, you know, so each of them had other characteristics that they were dealing with as well, in addition to the scientific pursuits that they actually did.
So Norm says, you've touched my puppy. I'm sorry, I couldn't control it. She likes attention too. You've touched on this a little, but I just wanted to ask, minimally invasive interventional treatment of obstructions and structural problems versus surgical treatment. Overall, which way is the trend line going? What does the future hold?
So if you look at the trend line is certainly toward minimally invasive, right? So that's key. The gold standard has been open intervention, like open surgery. And now that we're finding ways to minimize the impact to get the same result, but to minimize the need to, say, go on pump, you know, or have, you know, bigger cuts and operations, depending on what the condition is, that's where the trend is going. Say for people who have aortic aneurysms, abdominal aneurysms, the ability to close those without having to have the big AAA surgery, that's a tremendous benefit. People who had aneurysms in the thorax, thoracic aneurysms of their aorta, even surgery is difficult to treat those. But now there are certain devices, endovascular devices like stent grafts, that can be used to treat those as well. So we're able to do much more. We can reach better areas in the blood vessels, sometimes minimally invasive. The other part is just to make sure that it's as safe as possible. So because they often involve implants, and particularly because implants can clot, implants don't grow. There are other characteristics of them that we need to be aware of, and that's where the advances are being made to get them to come in and to heal more naturally. As we've heard before, that sometimes there's a healing response against them with scar tissue that can cause problems just as well as the problem that you were facing at first. And that's where some of the advances and some of the work needs to go as well. But clearly, like to Amy's point, that the open operations have been going on a downward trend. There's no doubt. That's irrefutable. And there are many more minimally invasive operations that are using for people who have heart disease. Just consider amputations as a form of surgery, right? And so people who have diabetes and gangrene of the foot, we're now able to, you know, use stents, balloons to try to help restore blood flow to the feet so that you can keep your limbs on. So that's, you know, that's a trend that we hope would continue, definitely.
Dr. Underwood, thank you. This is Norm. Dr. Sam Day has been trying to get online to ask a question.
So hi, Doc. Thank you so much for being here. As a heart recipient, I'm extremely grateful that you're here. I've dealt with a lot of cardiologists and all different kinds. There's many different kinds of cardiologists, as you know. So my question is, when we go for annual checkups and things like that, what type of tests do you recommend? Because a lot of people, you know, you don't really find the problems unless you do a stress test, for example, you know, so just comment on that a little bit, then I have one more question after. Thanks.
Sure. So for me, and just in general for screening, so community screening, I think that understanding the risk factors and knowing what to report. So basically it's history. So it's not really a test. It's just like listening to people to see if you have symptoms. After that, I think oftentimes the electrocardiogram is the one that shows up very well. So whether the EKG is normal or not can often give someone a lot of information. And if it's not normal, and then talking to them symptoms, it helps to point you in what direction. Stress tests, I think, are important, particularly for coronary disease. But you know that like a Holter monitor or some type of monitor is going to be better for arrhythmias, right, for irregular heartbeats. Just like an echo is going, echocardiogram is going to tell you more about the heart muscle function and how the valves are. So it kind of depends on what you want to know. But those three things, the electrocardiogram, the echo, and the stress test, and me as an interventional cardiologist, certainly the coronary angiogram is the gold standard for what's happening on the inside. Stress test indicates that you may need to be cathed, but those are the tests that we need to figure out how to use. Modern day, now we have the coronary CT scans, the CT angios that people can take to look for blockages, right, easily. Again, an echocardiogram is an easy test to take. It's ultrasound, put the jelly on the chest and look around. It gives us a tremendous amount of information. So those are tests that are not as invasive that I think people would be interested in as well. And you're certainly well aware of like a live core, the different devices that you can put your fingers on to detect irregular heartbeats as well. I think that, for people who have symptoms from those, that's going to be very useful too, because it brings it to our attention. You're at home, you felt something, you're able to capture it with your phone basically, and then you can bring whatever that is so that we actually see what's happening as opposed to you just describing things to us.
So one more quick question. So can you comment on, we all pretty much in this group, at least, we know the symptoms, but we know the common symptoms, but are there any other symptoms that people should be aware of? We know the normal ones, left side pain and all this stuff, but if you're having trouble, are there other things that could be that we may not know that it's a heart problem?
Sure. So, okay. So from the very basic part, so the question with the high triglycerides, the high blood pressure, high cholesterol. So those things aren't symptoms, but they're definitely there, right? So those would show up with your visit to the primary care doctor, like for your annual examination, your well visit, right? That your blood pressure is not under control. So if your blood pressure is out of control year after year after year, then you may not have a symptom yet, but there definitely is a sign there that you need to do something about it, right? Similar to the cholesterol, if it's out of control, you just don't address it, then that's a sign that's there. So then we get to the symptoms of what you're feeling. Most of them do go back to like the 4 or 5 symptoms of heart disease, but everyone may not feel the same chest pressure, left side of chest pain. So for the people, let's say in this group who have had coronary problems, you've had stents, bypasses, everyone would describe their angina a little bit differently, right? We have now recognized that women may describe that angina sensation in words that men typically wouldn't use. So it may come up as nausea, right? Or it may come up as a shortness of breath, and men may not actually use those terms to describe it. So I think that a lot of emphasis has been made on trying to understand when a person describes the symptoms of what they are, right? But the thing is like an oppressive sensation coming out of the chest, right? That's typically angina. The fluttering in the heartbeat, that's going to be palpitations. That'll be something with an arrhythmia, right? The weakness of walking, not being able to get up the steps, that's kind of the shortness of breath that we often use with heart failure. So those things are characteristic. Walking distances, having a pain come on your leg that makes you want to stop, or pain that comes on in your chest that makes you want to stop and rest. Those are key functions of cardiovascular disease that likely your stomach or anxiety aren't going to be able to reproduce. So I think that, I would say that those are the key symptoms. How they're interpreted and how they're described by people may be different, but there haven't been any new symptoms that have come about. So I will say this, for that cardiomyopathy that I spoke of, that there's this new medicine for. Many of those people have carpal tunnel syndrome too, right? So if you have people that have this combination of cardiomyopathy and carpal tunnel syndrome, we can hone down on the diagnosis, and there may be a therapeutic agent that's available for you that you can see. I wouldn't say that everyone who has carpal tunnel syndrome needs to have their heart checked, but it is something to keep in mind with that particular type of problem, right? The symptoms of having that cardiomyopathy are the same: shortness of breath, going, I can't exercise like I was able to exercise before, fluid retention. Those are heart failure symptoms that have, the same symptoms. They're just associated with other things.
Okay, I believe that we'd like to thank you certainly for everything you've helped us with today. I'm going to turn this over to Norm. Is that okay, Norm?
And Dr. Underwood, well, obviously everybody on this call today, we want to thank you for spending some of your valuable time with us today. And Dr. Underwood in particular, we actually got a 3-for-1 today. We need to thank you 3 times. From the clinical side, the information that you gave us and your presentation and the Q&A was absolutely invaluable. Learning a little bit more about what's going on now and what's coming in the future. Secondly, on the industry side, what's on the horizon is very exciting. And we really appreciate your sharing a little bit of insights, what's happening on the industry side, the R&D side. And additionally, thirdly, organization to organization. One of the things we were looking forward to today was learning a little bit more about how we can work more with ABC and other organizations similar to yours, where we can work together, physicians and patient advocacy groups, to work together to extend our reach to communities that really need what we're talking about here. So thank you 3 times. We'll just say a big thank you and a round of applause.
Oh, thank you.
Thank you, doctor.
Right, it's been a pleasure. Thank you.
Thank you, sir.
Thank
Goodbye.
you.